you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
God is wrist pain by doing over-aggressive high fives to his buddies.
Hey everybody, welcome back to the Emergency Ultrasound Podcast. Mike Mallon here today. Unfortunately, Matt Dawson can't be with us. He is currently giving birth in Lexington, Kentucky. So we're all giving him pushing wishes.
Thanks, Mike. Mom and baby are both doing great. I'm having a little trouble losing the weight, but other than that, things couldn't have went better.
Instead, we've got a surprise for you. We have a guest speaker with us today, Keith Curtis, who's got a good idea. And at first, I got to admit, I was a little skeptical of his good idea, but he's won me over the last month or so. And his concept is using ultrasound to assist in a cricothyrotomy. And Keith is here today, and he's going to tell us a little bit about that. Welcome, Keith.
Thanks for having me. So I want to talk about an ultrasound-guided, bougie-assisted cricothyroidotomy. Standing on the shoulders of people who have come before me, the bougie-assisted cricothyroidotomy has been shown to be quicker, subjectively easier, and have a higher success rate than traditional rapid four-step. So based on that, I would prefer to use a bougie-assisted cricothyroidotomy in an open cric. But I had the thought that why aren't we using ultrasound to guide the cricothyroidotomy? Couldn't we see the cricothyroid membrane? Couldn't we see the surrounding vasculature? Wouldn't it help comfort me in a time of stress in a procedure that I don't do often? And so I started to look into, is it possible? Is it easy? Can we do it? Can we teach it to others? So that's where I came up with the idea.
That's a great question, Keith. And, we are sort of taking ultrasound and replacing our fingertips with the ultrasound probe in just about every other aspect of physical exam, or at least, it seems that way to me in some aspects. So I don't know if the pendulum is just swinging in one direction or whether this is really, really more advantageous, but I'm interested to see what you have to say.
So, Mike, I think that's true that the ultrasound is replacing our fingertips for things that our fingertips aren't very good at, like palpating stones in the gallbladder and evaluating the aorta, things like that. But I feel like my fingertips are pretty good at finding the cricoid membrane. So I don't know about this. It seems like possibly just an extra step to me. I mean, I'm going to listen because I know Keith Curtis and he's smarter than me, but at this point I'm pretty skeptical.
So let's get right down to it.
Well, the first thing I had to do was look at the literature. Has somebody done this before? What are people doing in this? And one of the first things I came across was a paper by Nichols in the American Journal of Emergency Medicine, where 2 emergency medicine physicians went into the cadaver lab and looked at 50 cadavers and see if they could identify the cricothyroid membrane. And indeed they could. 50 out of 50 patients, they were able to identify the cricothyroid membrane. In their paper, it was in about 24 seconds on average.
So 24 seconds to identify the cricothyroid membrane. This is on cadavers, right? So I guess I'd like to know, what are these cadavers like? Are they cachectic? Are they large BMI? Do we know anything about that on the paper, Keith?
Well, what I thought was we would get into the cadaver lab and see how it turned out for us on different BMIs and different cadavers, cachectic and otherwise. And in our brief experience, in my brief experience in the cadaver lab, it seems that BMI does not play much of a role. In their paper, they did say it was irrespective of BMI, they were able to identify the cricothyroid membrane. But in my experience, a larger BMI, more pretracheal tissue may actually be advantageous in finding the cricothyroid membrane because you get a flush interface of the probe with the pretracheal tissues, and also you have a little bit of depth to look through.
Okay, fair enough. What's this other study you're citing here in the British Journal of Anesthesia?
So this was a study of anesthesiologists, and what they were doing were percutaneous tracheostomies. So they were going between the cricothyroid membrane and the first tracheal ring, or between the first and second tracheal ring, and they were using ultrasound to guide needle tracheostomy. What they did was they placed a needle into the trachea, placed a wire, and then confirmed by CT whether the wire had been placed in the right place. They had a success rate basically 100%, but one of the cadavers they had to make 2 attempts because the needle was displaced.
All right, cool.
This is a newer paper that just came out in Critical Care in 2011. Dr. Rajiji. This was a critical care physician who did bedside ultrasound-guided tracheostomies right in the intensive care unit. He did 13 tracheostomies and had a success rate of 13 out of 13, and he confirmed this with bronchoscopy.
Sounds pretty cool so far.
The other thing he did was identify the paratracheal vasculature under ultrasound guidance, which was also very interesting. So what are we going to do with this information? How are we going to translate this into an ultrasound-guided cricothyroidotomy? So based on a paper by Dr. Hill in the Society of Academic Emergency Medicine, they had shown that the bougie-assisted cricothyroidotomy was quicker, with a median time less than half of that of the four-step, and subjectively easier, as reported by students and experienced faculty and residents. So I wanted to use a bougie-assisted method with my ultrasound cric.
Okay, Keith, so I understand that you can ultrasound the cricoid membrane, but why? What's the advantage?
So why ultrasound then? If this is already faster and better, why ultrasound? So there was a study by Elliott in anesthesia that showed that anesthesiologists were not very good at identifying the cricothyroid membrane tactily. Even in anatomically normal models, quote unquote, none with high BMIs, none with any anatomical variants, they were only able to identify it 30% of the time. And those who did identify it, only 11% of those found the midline. So when they confirmed with ultrasound, these anesthesiologists who evaluate the airway on a regular basis were not that good at finding the cricothyroid membrane.
So you're saying we've already got this awesome technique, the bougie-assisted cric, and you're going to make it more awesomer by using ultrasound. Is that right?
I hope so.
Okay.
So we already talked about why using the bougie, and we talked about Dr. Hill's paper. Hey, here's just a little reference of that. So in their trial, they had a failure rate of 1 out of 10 for bougie and 3 out of 11 for the rapid four-step. So not only is it faster...
3 out of 11?
3 out of 11.
That blows my mind. So we're talking about a life-saving procedure, something that every single one of us trained to do in our emergency medicine training, and still we're missing 30%?
Yeah. And even with the bougie, 1 out of 10, that's not great. 10%.
30%.
Yep.
30%. Not 0.3, not 3, 30%. We talk about risk and what risk you're comfortable with. I'm pretty sure 30% is not a risk I'm comfortable with.
Right. And if you could use something to make it easier, make it more comfortable, and guide you visually, I think you would want to use it. It's just like pericardiocentesis in the emergency department. Nowadays, you'd be hard-pressed to find somebody describing this procedure without at least mentioning ultrasound. And if you had the ultrasound by the bedside, why you wouldn't use it, I don't know.
All right, Keith, so you've convinced me.
Fine, you've convinced me too.
You've convinced me that there's an area of need here, that we're not very awesome at performing even the bougie-assisted cric. I mean, there's a failure of 1 out of 10, and then, geez, with the conventional cric, a failure of 3 out of 11. I mean, granted, small numbers in this study. We're not looking at 100 different cadavers, and cadavers are always different than real people. And in my experience, they're different in the sense that they're easier. I mean, in the real people is when you got blood spouting all over the place. So I'm really interested to see how you do this.
Yeah, I think doing it in a cadaver is, of course, artificial, and there's not much other way to do these studies. We don't have the numbers that we need to do it in live human beings. And I would suggest that with a lot of blood in the scene, the ultrasound is only going to help you more. You know, so ultrasound sees very well through liquid, and with a lot of blood in the way, ultrasound is going to be your eyes.
All right, so how do you do it? Let's do this.
So the way I'm proposing you do it is holding a linear transducer in your non-dominant hand with the probe marker towards the patient's head, putting it on the anterior of the neck, and sliding back and forth until you find the cricothyroid membrane. And what the cricothyroid membrane looks like in this orientation is a sharp A-line. An A-line is a very bright hyperechoic line that you see at an air tissue interface, just like when you're looking at the lungs for pneumothorax.
Well, let's show a picture of that. It looks like you've got only a few tools, though, to get started. Is it just the bougie tube and a scalpel? That's all you need?
Yeah, and the syringe to inflate the cuff. That's all you're going to need.
Okay, good. Well, let's see if we get some pictures here. So first you're saying you're going to take the ultrasound, linear transducer in the longitudinal plane. So I've got it up and down on the patient's body, the probe marker towards their head, and I'm holding it. So I'm right-handed, so I'm going to hold it with my left hand.
Right, and you're going to stand at the patient's head.
Okay, so I'm about to tube the patient. I can't tube the patient. I can't ventilate the patient. So I grab my ultrasound probe because I had the ultrasound set up previously. I'm ready to go with my ultrasound machine, and I just grab it with my left hand and take a look.
Exactly.
Okay, so something like this.
Yeah, this is a picture of me attempting it on the first cadaver.
Okay, so it would look exactly like this, except there would be poop in my pants.
Yes.
Okay. Just making sure. The poop would be all in my pants.
Everywhere.
Running down my leg. Okay, good. No, so this is what it looks like. So here we see the probe over the anterior neck, the probe marker pointed towards the patient's head. The anatomy on this cadaver looks terrible, Keith.
Yeah, this cadaver, you could not palpate any of the structures. The laryngeal prominence, you could not palpate. The cricothyroid membrane, you certainly could not find.
So say you didn't have ultrasound. How would you have gone about getting an airway on this cadaver?
So if this is a can't intubate, can't oxygenate, can't ventilate, you're going to have to do your cric, and what you're going to have to do is a vertical incision to dissect the tissues down. And this patient had 2 centimeters of subcutaneous tissue. So you're going to be diving down, avoiding vasculature until you can find your anatomy.
Okay, so you're either diving down into the deep or maybe doing a perk cric or something else, one of these other procedures, but definitely not an easy 4-step procedure is what you're saying.
Not at all.
Okay. So I guess this is what you're seeing with that linear transducer?
Yeah, this is a video. If we can freeze on the final frame, you'll see the anatomy come into view.
So you're basically are you moving laterally and on this neck here to finally find that midline?
Yeah, you can either rock the probe right to left, or you can slide the probe right to left. Sliding probably covers more ground, and what you're looking for is the thyroid cartilage, the cricothyroid membrane, and the cricoid cartilage. So here we have a picture which shows the thyroid cartilage, the laryngeal prominence is in the far left of the screen, and then the thyroid cartilage dives deep. There you have the step off of the cricothyroid membrane with a bright hyperechoic A line, and then you have the cricoid cartilage, which may be hyperechoic, it may be hypoechoic, but it always has some posterior shadowing. And between these two structures, you find the cricothyroid membrane.
So the thyroid cartilage is that really bright white line that's giving me a lot of shadow because it's thick, right? And then the cricothyroid membrane, you're saying A line, as in A line like we see on the lungs?
Yes.
Okay, so it's basically hitting an air interface and giving you some of that, I guess, just gray shadowing behind it, huh?
Yeah, and it's very impressive on ultrasound. When you're swiping through the pretracheal tissues back and forth, it jumps out at you as this very bright hyperechoic structure that you really can't miss.
Okay, so now I know what I'm looking for. Let's go back to that video again. All right, so that's us moving back and forth until we find midline, and when we find midline, you get the very obvious 3 bright lines with the different colored shadows behind them.
Exactly.
Okay, that looks pretty easy. I feel like I can do that. How long does it take you to find this?
You know, so far I've done this on 10 cadavers, and it averages somewhere around 7 seconds, but many times it's less than 2 seconds.
That's pretty good. I mean, I guess that's about how long it takes for me to put my index finger on the neck and convince myself that I'm feeling the cricothyroid membrane.
Yeah, in a patient that has good anatomy.
Yeah, good point. Okay, so you found the cricothyroid membrane. What's next?
So the next is sort of borrowed from the bougie-assisted cricothyroidotomy technique. I didn't want to change much about this because I wanted to compare our times and success rates to the times and success rates of Dr. Hill's study. So we're going to incise the cricothyroid membrane with the number 20 scalpel. This is in our dominant hand, and it's a single horizontal stab incision. There's no vertical dissection. There's no worrying about the paratracheal vasculature. Just a single stab incision right over the cricothyroid membrane.
What if I only have a number 19 scalpel?
You can do it with a 10. You can do it with a 15. 20 is just bigger and better.
So would a 22 be better then?
Probably.
Bigger's better, right?
Bigger's better.
So I'm going to get like a number 100 scalpel
if you've
the
got
next
it,
time I'm doing this.
You can incise right through the trachea.
Okay. All right. So we incise through the trachea.
You let go of your ultrasound probe because now you've held the opening with your scalpel. You just rotate the scalpel 90 degrees to make room for your elastic gum bougie, and then you just insert your elastic gum bougie through the tracheostomy.
All right.
Here's a picture of making the incision. So you still hold the ultrasound probe in your hand. You sort of line the cricothyroid membrane up with the middle of the ultrasound probe, just like you would do with any other procedure. And you make the incision, and then you let go of the probe.
So I'm lining up the scalpel to the middle of the probe. That way I know that my scalpel is going to dive into what's ever in the middle of the screen, right?
Exactly.
Okay. And it looks like you're sort of holding the probe just a touch to your left.
Yeah, I've rocked it off the midline here so that I can make room for my scalpel.
But you're still pointing at midline with the probe.
And can see what I'm cutting.
Okay.
So after that, you have the bougie in. You want to feel, if you can, for tracheal rings. This is difficult, especially in a high-pressure situation with blood everywhere. Feeling for tracheal rings is going to be difficult, but possible. More importantly, you want to feel for hold-up. You advance the bougie until you feel hold-up, which is basically hitting the carina or one of the large bronchi. If you don't feel hold-up, you could possibly be in the pretracheal tissue, which you could confirm by ultrasound. But if you don't feel hold-up, you better try again.
So this is hold up like you're talking about when you're using the bougie for, like, even with laryngoscopy. So I advance the bougie, it gets stuck at the carina as opposed to going into the esophagus and just twirling up in the stomach. So that's that hold up you're talking about, that immediate sort of like oomph, it just stops.
Exactly. It's exactly the same.
Okay, cool.
So once you feel the hold up and you're confident that the bougie is in the trachea, then you just glide your 6-0 cuffed endotracheal tube over the bougie. You bluntly dissect the tissues as you advance the tube, and then you remove the bougie.
You're selling me on these adjectives. You glide the tube over the bougie because it's gonna just glide, right? And then you just bluntly dissect because it's just gonna be the easiest blunt dissection you've ever done. It's just like that, right, Keith?
I'm sure the blood in the field will lube it nicely.
Okay, great. So let's see here. I think we have a video. Is that right?
Yeah, we do. We have a video here. The first video is one of a repeat on the first cadaver showing the step-by-step process. So we already have an incision in the anterior neck where we'll show the original video at the end, making the first incision. But here, through the incision, we're going to show the procedure.
So here you're looking, you stab with the scalpel, you're doing that rotation you were talking about to make some room for the bougie, drop the probe, stick the bougie in, get your hold up right there, okay, and then you're just going to slide the tube over. You're going to glide the tube over, right, there we go. Just glides right in.
Beautiful.
That's pretty quick.
Yeah,
Is it still that quick without the cut in the neck already?
So when we see the original, it's not going to be that quick, but I'm talking through it. In the procedures that we've been doing with the past 11 cadavers, it can be as quick as 16 seconds from picking up the ultrasound to inflating the cuff.
16 seconds. No way.
Yep, it's possible.
16 seconds. All right. So how does that compare to these other studies you're talking about?
So looking at the Hill study where they compared the bougie-assisted cricothyroidotomy to the rapid 4-step, they had a median time of 67 seconds compared to 149 for the 4-step. And here we're looking at a median time of 32.5 seconds. So half the time of the bougie-assisted, which as far as we know is the fastest that we have.
Okay, so just to be clear here, Mike, myself, and Keith, we understand that a series of anecdotes doesn't equal data. We're not suggesting that this method is twice as fast as that other method described because that hasn't been tested. Those haven't been directly compared. What we're doing here is Keith is merely describing a technique. So let's talk a little bit more about the methods of how he did this and how exactly he got that phenomenal time that he quoted.
So who's doing these procedures? Is this all you, Keith?
No, it's in the cadaver lab, you mean?
Yeah, I mean, are you training people to do this? How much training do you have with these procedures?
So I first trained by trying to find the cricothyroid membrane on my wife, and and then on myself. And that's about as much training as I had. Then I looked up to see what other people had done, and I'd seen that they've looked at the cricothyroid membrane in the transverse plane. So you can see the cords, you can see a little more of the anatomy, but I felt like it was more difficult to perform the procedure. And I found some images of the cricothyroid membrane in the longitudinal position, which we've shown here, and I found that to be easier. So not a lot of training. I'm not an ultrasound. I'm not RDMS. I'm just a second-year resident, so I think it's very doable.
This is interesting. Okay, so you're not highly trained in ultrasound. You didn't spend a lot of time looking at a lot of cricothyroid membranes. You just really looked at yours and your wife's.
Right.
And you've managed to take the time to complete this procedure down by half.
Right, and I don't think it matters how much training you have or not. It's such an identifiable structure and such an easy look. I think it really doesn't matter.
So no failures?
So far, no failures. So they had 1 out of 10 in the bougie assisted, 3 out of 11. I've done 11 and 0 failures. We're only counting 10 of those because the first one was, as you see here in the video, and the timing was based on explanation and going through it step by step in a slow way. So I'm not using that one in the study. So I'm calling 10, 0 out of 10.
All right. That's pretty interesting, Keith. I'm interested to try this. I don't know when the next time I'll get to try it is. I've only done a couple of Crics in my life, and I can tell you they all took more than 16 seconds. So I'm interested to see what's really going to happen in the field, as I'm sure you are.
Yeah, and I'd like to see other people do this study as well. I know Matt Dawson was thinking about doing it in Kentucky, and if we can do it in different places with different people, if they find that it's more difficult, or if I'm wrong, I'd love to know.
That's right, Keith. I am stoked to try it. This looks pretty incredible. However, I don't have an unlimited number of bodies that I can try this on. I mean, sure, I am from Kentucky. I do have plenty of cousins who can give me all the bodies that I need. Those aren't medical grade. So what would be really cool is if we could have a multi-center trial. So if any of you out there are interested in working with us on this, let us know. We can develop some good, nice methods and compare this to standard method and see if it actually is any better. We don't really know the answer to that, and it would be cool to find out.
Cool. Thanks a lot, Keith. It was great having you on. We've got a video of Keith performing the actual initial procedure on the cadaver with the fresh cut, and we're going to go ahead and play that now for you guys, and we'll see you soon on the Emergency Ultrasound Podcast. Thanks.
Thanks for having me. Here we're performing ultrasound-guided, bougie-assisted cricothyroidotomy on the first trial patient, a cadaver in the cadaver lab with high BMI and more than 2 centimeters of subcutaneous tissue. Almost impossible anatomy to identify by tactile feel, and the procedure will involve identification of the cricothyroid membrane with ultrasound using a linear transducer held in the non-dominant hand in the longitudinal orientation with the probe marker towards the patient's head, as you can see here. Sweeping back and forth across the midline, identify the cricothyroid membrane seen here as an A line. Insert a number 20 scalpel horizontally with a single stab incision through the cricothyroid membrane. Rotate the scalpel 90 degrees to allow space for the elastic gum bougie. Insert the elastic gum bougie through the single incision, feeling for tracheal rings, and hold up. Once the elastic gum bougie is inserted into the trachea, gently move back and forth, feeling for tracheal rings. Advance further, feeling for hold up. Once hold up is felt, insert the 6-0 endotracheal tube over the elastic gum bougie and forcefully, bluntly dissect the tissue, inserting the 6-0 endotracheal tube into the trachea, removing the elastic gum bougie, and inflating the cuff. Confirm endotracheal tube placement with auscultation, end-tidal CO2, and EGD device.
You're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.